Morning.
Good morning.
Good morning.
Okay, it's just 9 o'clock, and we have a lot of material to cover, so we're going to go ahead and get started. I know a few people may be popping in, and so this is the Encounter Data Submission Guidance webinar for developmental disabilities, home and community-based services. And just a couple of housekeeping issues. First, just to let everybody know that this is being recorded, because we're going to go ahead and post this on the Dale website so that people who aren't able to attend today can listen in at a later date. There are a couple of features that we're going to be using on this Zoom. Imagine by now everybody's pretty familiar with Zoom, but in case you're not, if you hover over the bottom of your screen, you'll see a section that's called chat, and we're going to use that. You can use that chat box to ask questions. So what I'll be doing is going over sections of the guidance document that I had sent out earlier this week, and then I'll be pausing and we'll review the questions that are in the chat. And then if there are additional questions, people can use the feature for raising your hand and asking your question. So the raising hand feature is if you go into reactions and click on that, you'll see where there's a place to raise your hand. So one thing to remember though is after you've been called on and you got your question answered, you can lower your hand. So if everybody could just stay on mute. We don't need people's cameras on either. So if you want to turn that off, but when it's time for you to ask a question, you can unmute yourself if you'd like to ask it live instead of in the chat. So the other thing is I want to welcome everybody to this training. I know this has been a really rough past year for everybody, and that people have been working super hard to make sure that people's needs are met in developmental disability services. And just want to let you know how much we appreciate that. And I know that this is an additional task to add to your many, many tasks that you're trying to deal with as we work our way through this pandemic. And hopefully, we're seeing the light at the end of the tunnel with vaccinations, but I know we're still in the thick of it. So anyway, I appreciate your time with attending and then shifting into implementing this reporting of encounter data. The other thing, I know it's kind of dry material, so I can't think of any way to make it more exciting or interesting. So I'll apologize in advance that this is going to be not too thrilling webinar. Okay, so I'm going to go ahead and share my screen. So let's see here. Here we go. Okay, so I assume people can see this.
Yes.
Yes.
Okay. So the topic is the review of the Encounter Data Submission Guidance for Developmental Disabilities, Home and Community-Based Services. And my name is Claire McFadden. I'm the Dale Deputy Director for Payment Reform. previously I was the DDSD director and shifted over to this role last year. And I have some of my partners from the state on this call as well to help answer questions if needed. Jessica Bernard, who's our senior compliance auditor and program consultant with DDSD. She's relatively new at the division, took over the role for Jennifer Perkins, who some of you may have known before. And she's heavily involved with the overall payment reform project for DD. And Erin Flynn is our healthcare program director from DEVA, and she's part of the payment reform team, and she's been part of the DDSD payment reform project. And a special thanks to Howard for allowing us to use their Zoom platform because we didn't have a platform large enough to accommodate everybody. So thank you, Howard. So what we're going to do today is I'm going to walk you through the encounter data submission guidance. I will stop as I am going through the document, and I'll ask if you have questions. And as I'm talking, if you have a question, go ahead and type it into the chat, and then we'll pause when I get to that section. We'll review the questions in the chat, and then if there's additional questions, you can use the raise hand function, and we can answer other questions. If for some reason we're getting too many questions, just know that there will be some time for questions at the end, hopefully. But if not, if we don't get to every question, my intent is to compile all the questions that are typed into the chat box, and we'll send that out later. If you think of additional questions afterwards, email me. And just so you know, that Jessica and Erin and I are, as our payment reform team, we are very happy to help agencies with their implementation of being able to report encounter data. And we're happy to answer questions, or if you need some targeted technical assistance to work around some issues, we are happy to provide assistance. So you can contact me and we can figure out what we can do to help you.
Claire, this is Erin. So sorry to jump in. I just wanted to know, I was scrolling through the names. I think we have a couple of our Gainwell provider services representatives on the line. I think I saw Margaret, and I'm not sure about Nikki. Sorry, I've got my little 5-year-old here with me making noise. So maybe they could just to note that they're on the line for support of questions as well.
Great. Thank you, Gainwell Partners. So providers know that they have provider representatives that can assist with any submission and resolution of claims that are sent into the MMIS. And so if you have questions of that nature, that we can call on them to help answer our questions. Okay. So why are we changing how services are reported? So right now, agencies are reporting their services in what's called the monthly service report system. And that MSR system has been in place for, I don't know how long, decades. And it's a really old platform, and it has a lot of limitations. And there's also gaps in what's being reported to the MSR. We're not able to have agencies provide complete reporting in the MSR, and the accuracy of some of what's being reported is not what we need in our agreement with the federal government. So we made a decision that we're going to move from having the reporting into the MSR system, into the Medicaid Management Information System, which is the place where providers send their bills to get paid through Medicaid. So it is a federal requirement that we have complete and accurate reporting. So that's another reason why we're making this change. Several years ago, the Vermont State Auditor's Office said that our method of accounting for what services are delivered to people was in need of improvement. And so that's another reason. And it's a major component of the overall developmental disabilities payment reform project, which has a goal of enhancing the transparency and accountability. So one of the issues is that we pay for services through a bundled rate. And previously it was a daily rate where like all the services somebody got were just added up and divided by 365. And then that's how the services were paid for. And then the reporting of what somebody actually received by service category was in the MSR. But we don't have enough detail with that reporting to be fully transparent and accountable for our service delivery. So that's why we're shifting into the MMI. So a good thing is that once you start reporting into the MMIS, you won't have to report into MSR any longer for developmental disability services. I know this is it's a difference with the Department of Mental Health. Their payment reform project is still requiring MSR reporting as well as encounter data reporting into the MMIS. But for us, we're just going to have you report into MMIS. So what is encounter data? So it's a record of what services a person received and includes all these components. When a person got it, what did they get? Who delivered it? How much did they get? Etc. And it's very similar to the way that providers bill for what's called fee-for-service claims. But in this case, the encounter claims that will be submitted into MMIS are going to pay $0. So in a fee-for-service world, you deliver a service and that service has a price related to it. And then when a claim gets put in, then Medicaid pays for that service back to the provider. In the case of encounter data, the payment won't be coming back to the provider for that. The encounter data will just be our record of what got delivered, and the payment for services will continue as it is now, which is providers are submitting a monthly bundled claim for all the services that are authorized for a person in home and community-based services. So what's changing? Again, we're going to shift from reporting in MSR to MMIS. There's new codes for the reporting of each service. And we're moving from the codes that were used in MSR to the nationally recognized service codes. And we'll get to that a little further along in this webinar. And it is included in the encounter data submission guidance document. And we've added codes to more accurately reflect the full range of services that are being provided. So under home and community-based services, we have the categories of services that are defined in the system of care plan, like service coordination, like respite, like employment, community. But then we actually allow for some creativity and flexibility in how those funds are used. And so what we're, for example, like we let people use their respite dollars to attend camp. So what we are doing in adding some additional codes for encounter data is reflecting some of the actual services that people are getting. So now there will be a code for reporting that somebody went camp. We also have, we've added a code to allow people to report participation in like Project Search and post-secondary education opportunities like college steps and Think College when the home and community-based services funds are being used to pay for that. So we'll be able to track more precisely what people actually are getting. And so then we are going to, because we're now using those national reporting codes for services, we will be needing to follow the national correct coding rules when submitting claims. So a lot of the guidance that's in the encounter data submission guidance is reflective of what's required. But yeah, I know that a lot of agencies, not necessarily the specialized services agencies, but the designated agencies are quite familiar with correct coding because of a lot of the work that they do with submitting claims for mental health. There's a lot of familiarity there. Okay, so what's not changing? What we're not changing is the services that are available under home community-based services. We still have the same set of services that will be available. And like I said, we're just expanding some of the codes that are used to reflect what's available in HCBS. The documentation requirements are not changing. So you still follow the same documentation requirements that you are following now. So your records of service delivery and notes would follow generally what's in the ISA guidelines for documentation. And we are not requiring a specific note for every encounter that's submitted to the encounter data as an encounter data claim. There doesn't have to be a one-to-one correspondence there. You will just continue to document services as you are now. The worker qualifications for services are not changing, and the method of paying providers is not changing. We're still going to be paying you that monthly bundled rate. So here's some of the things that agencies are going to have to do. I know we've been talking about this for like a year, but just I know people are at different stages of readiness for getting ready to report all this encounter data. So just as a review, providers are going to have to figure out how the information is going to get from the staff who's providing the service to flow up to being able to report it as an encounter claim. Agencies will have to figure out what they need to do to update their electronic health records or other systems to allow for accurate reporting. You may need to examine like your workflow or business practices to make sure that you have a process and procedures in place to make sure that information gets from wherever the service was delivered up to a claim. And what another component of this is that there are services that are provided by workers who are paid through ARIS, or there are other services that are expenses that are paid through ARIS through non-payroll request forms. And ARIS will be sending that information to each provider who then will be submitting encounter claims, except for transition 2. Their ARIS will be submitting them on their behalf. But for all the other agencies, ARIS will send over information about the encounters, and then the agencies will be submitting the encounters themselves. And so there's some work that providers need to do in terms of how they're going to incorporate that information into the submission of claims. And then another piece of work that needs to be done is providers will have to figure out, okay, if I have a subcontractor or a service is not like provided by their staff, and so it may not be running through their electronic health record, but it's an invoiced service, the agency will have to figure out how they're going to collect information and then how that gets loaded into an encounter claim. And then the agencies will have to implement all these system changes, make sure staff are trained in any new procedures. And then once encounter claims start getting submitted, they'll have to figure out if they get a denial of a claim, how they will deal with any denials. So what generally happens is the encounter data goes to MMIS, and if everything's done appropriately, then the Medicaid sends back a notice to the provider saying, yep, that claim was good and that's been processed. Or if there was some problem with it, a claim might deny. And so in those cases, the agency will have to figure out why the denial happened. The MMIS system, when they get their notice back, there are reasons. It tells you why a claim was denied. But and then the agency will have to troubleshoot that and figure out what the problem is, and then resubmit the claim. Okay, so I just want to let you know how encounter data is going to be used. So initially, and this is all part of the larger DDS payment reform project, it's primarily going to be used in the beginning as a record of service delivery. And as agencies ramp up and start reporting, we're going to be monitoring the encounter data. We're going to be looking to see if it looks like agencies are doing it correctly, and if they're doing it completely. And then, we may reach out, like if we see a problem, we'll reach out to providers to see what the issues are. But eventually, the payment reform project, what we need as part of designing a future payment model is 6 months of complete and accurate encounter data. And that information will be used to help us design a future payment model. So what we'll be looking at is, based on people's needs, what do people typically receive for services? And we'll be able to tell that through the encounter data. And that will help us figure out a future payment model. Later, the idea is that once we determine what the new payment model is going to be, and it's been implemented, the encounter data is going to be used for the purpose of reconciliation of the payments that are made to agencies, and then what the services are that were provided. So what I mean by that is, let me go to the next slide. We actually haven't figured out exactly how the reconciliation process is going to work, but as a general concept, agencies are going to be paid based on their approved budgets, and there's like a total dollar amount that will be calculated for a year for that particular provider. So it'll be all the approved budgets for all the people they serve added up for the year, and that's a dollar amount. And then we'll be looking at the encounter data, and the encounters will have dollar amounts associated with them. In some cases, it'll be a standard uniform rate, which we haven't determined yet. And some of the other encounters will be based on, it'll be more cost-based. And so then a calculation will be done to determine, okay, what is the value of the entire amount of service that was delivered by that agency for that year. And then that will be compared to how much the state paid for service delivery for that year. And then if, we haven't established any particular threshold, but what we're anticipating is that if the service delivery is below a certain threshold, the provider may need to pay back some of the funds that they were paid because they didn't technically earn them because they didn't deliver services. So that's kind of where the future use of encounters data is going. Again, there's still a lot of things to be determined with the payment reform design, so not a lot of these things are set in stone. Okay, I'm gonna stop right there and let's see if we have some questions.
in the chat, Claire.
Okay, I guess I hit the chat to see them, right?
Yes, I can also read them if that's easier.
Okay. Okay. I have, the first one is, well, I think I have it correctly. Oh no, here we go. Okay, the first question I answered already. Yep, we're recording this for later. And we will post it on the Dale website. We have a question. UCS implemented a new EHR in October. When our MSR was built, we were advised not to include DS clients. Will this need be addressed? Okay, so it makes sense that they did not include the need for MSR in your new EHR because we're moving to MMIS. So you won't need to report into MSR anymore once you start reporting your encounters into MMIS. So hopefully that answered your question.
Hi, this is Kara.
Yeah.
So we haven't been reporting since October. So there's,
Okay.
yeah.
Okay, that's fine. Honestly, to tell you the truth, because of the unreliability of the MSR data, Dale hasn't really been looking at it. So it's okay.
Great, thank you.
Okay. Okay, I'm still looking. What is the anticipated start date of the accurate encounter data 6-month window period for payment reform look back? Okay, that's a good question. So what we're anticipating doing is, like I said, we're going to monitor your submissions of encounter data. And when we are pretty confident that you're reporting everything and things look accurate, then we'll start the clock, and we will reach out to agencies to verify, like if they feel like they are at the point where we can start the 6-month clock. So that's what we're going to do. So we won't do it without notice, and we'll want to reach agreement that we both agree that it looks like it's pretty accurate and complete. Okay. All right, on my chat box, that's the end, I think. Is there any other? Okay. Are there any other questions at this point?
Claire, this is Jennifer. I was just wondering, this PowerPoint that you're sharing right now, was that sent out? I didn't see it in the email with the guidance.
No, but I can send that out for sure.
Okay, great. Thank you.
Hey, Claire, this is Dave Candamella. I just got a quick question on the reconciliation. And I know you are not there yet and not everything's
Okay.
wrapped up. I get that. And is there any discussions or thought process to if a provider actually at the end of that year actually provides more service and not rather less for a return of funds, but more service and being compensated for that?
That's a good question. So we're not sure exactly how that's going to be structured yet, but in some of our initial discussions, one of the problems is, the legislature appropriates us a set amount of dollars, and it's likely that, we won't allow providers to go over a capped amount. But again, that's not a settled deal. There could be potentially, the other option would be that, let's just say there's a, plus or minus, and the, maybe your authorized amount, you could go over by only a certain percentage. So that's a potential future way that we have it structured. But ultimately there would be an upper cap because we only have what we have for money.
Okay, so I thank you for that. I'm hearing there's maybe some wiggle room for if an agency is working with a very challenging individual and those support needs are more than what is available to be supported initially. I'm hearing that there may be some flexibility.
Right, and just keep in mind, like what we're anticipating around the future payment model is, so a provider would get, like, let's say they get $10 million. And then, some people may underutilize and some people may overutilize. And then when we do reconciliation, it won't be, by person by person, it would be the agency on the whole.
I
So,
got you.
yeah, so there'll be some flexibility there for the ups and downs across people.
Thank you.
Okay,
There, Bill Claesons has his hand raised as well.
okay, Bill?
Hi, good morning, Claire. To kind of follow up on that same train of thought, will there be any reporting or indicators during the year of how an agency is doing in aggregate? And then also, are you talking about a calendar year? So like, I think you said it was 90 days, so it'd be 90 days after a calendar year, or is it 90 days after a fiscal year? Because if there is a reconciliation and there's a payback, it may have implications on a fiscal year performance or revenue earnings. So I'm just curious if you've got any direction on that yet, or to be determined.
That's definitely one of those to be determined, but I think we're leaning towards fiscal years since that's how we are currently organized, but I'm not sure that will be the final answer.
Okay, and what about the possibility of getting an indicator of how we're doing compared to the target or the amount that we've been allocated? If we're underperforming, I guess there's a variety of questions here. If we're underperforming, there might be a data reconciliation. We've been talking about that with the DMH partners, making sure that we feel like our data might be different than what you're seeing, and reconciling that before there's an ultimate reconciliation and possible payback. So hopefully that can be considered as well as you flesh out these items. Yes,
definitely. Yeah, we will. We definitely need to think about that. And, one of the things that we had been talking about was, so one thing is providers will be able to do some data analysis too, because you'll have your paid, you'll know what you got paid or what you got acknowledged as approved claims. So you should be able to run some data yourselves, but also we will be running data. I doubt that we would wait all the way to the end of the year to do that, because I think we would want to get a read, partway through the year.
Thank you.
Okay.
This
All
is
right. And any other questions at this point?
Claire, this is Jennifer. Did the PowerPoint say at the end of the year when we're doing the reconciliation, the percentage that we're supposed to be within?
No, we haven't determined that yet.
Okay.
And, one of the thoughts is that, as we transition from the current way we pay for services to a new payment model, that there may be some flexibility in that, threshold. So one of the thoughts I've had is early on in the when we start doing reconciliations under the new payment model, maybe the threshold will be wider, and as we implement to cushion any transitional issues, and then narrow down for future. But again, we haven't decided that, and when we get to the design of the payment model, we're definitely going to be engaging all the stakeholders, of which providers will certainly be a major stakeholder to have input into how we should set it up.
Okay, thank you.
All right.
Okay. Just wanted to check, David. Sorry if I say your last name wrong. Canamella, your hand's still up. I think you might have just forgotten to put it down, but just wanted to check and see if you had another question.
No, I'm all set. Just a sticky screen. I'll get it off.
Thanks.
Hey, Claire, this is Bill again.
Yeah.
Just another quick follow-up. If you did implement on a fiscal year the reconciliation, would you be then, the first reconciliation would be for fiscal 23, or would you be doing it for fiscal 22? Since it 6 months from now is like 3 months into fiscal 22.
Yeah, we're not planning to do the reconciliation process minimally until we have the new payment model designed and implemented. So it's a number of fiscal years out.
Thank you.
So this initial phase will be really good for, ramping up and learning. Okay, I'm going to move to another folder here, and here we go. Okay. So I'm going to start going through the guidance now. And again, I'll stop at different locations and you can ask questions. And keep using the chat box. That seems to work well. All right, so this was sent out Monday. I had originally sent out a draft of this, but and then I got some feedback and then created a final version that I sent out on Monday. So if you have more than one document in your inbox somewhere, this has now been posted to the Dale website, and it's version 4 with this date on it. And just it's we keep updating which version it is, because we know that this is a working document. There's likely to be changes as we roll out into implementation. And but we'll always inform you if there's a new version that's coming out, and the start date for that if there's any changes. So just so you're aware. And again, this encounter data is just for the home and community-based services, previously known as waiver. So it does not apply to fee-for-service type billing. So you have your table of contents, your glossary. Okay, so just again, what is encounter data? It's the record of the discrete services that are being provided to people in home and community-based services. So your service coordination, your employment, your respite, et cetera, et cetera. And what's different about this is they are zero paid claims. So these encounters will be submitted, and the MMIS system, based on your use of your provider ID and the codes and modifier combinations, the MMIS system will recognize these as DS encounters, and they'll pay a zero amount back to the agency. So as I mentioned before, the requirement to track and report what services have been delivered to people in developmental services, it's long-standing. That requirement has been there basically forever, and it hasn't changed. The only thing we're changing is that we're moving it from reporting into the MSR to the MMIS system. There are a few slight changes in the service definitions, and you'll see later in the document. So the service definitions currently sit in the system of care plan and in the Medicaid manual. And so what we're doing is making some slight changes. All the service categories are still available, but based on how we're asking for reporting of encounters, there's a little bit of change. And in Appendix C, if I can get to that. Appendix C is what's reportable as a service. And in each section, you can see that there's a service definition. So if there's a slight variation in the definition, it would be right here in that part of the document. Okay, go back. Oops, sorry, I'm not making it easy. And then we have added some additional codes and service definitions to more accurately reflect some of the services. And we'll get to that in a little bit. I'll point out some of those. This section is just your general Medicaid provider policies and billing and forms. And so these are just general DIVA resources that you can access that help you with the claims process. And again, your Gainwell service rep is available to assist you if you're having trouble. So one thing to keep in mind is that the reason we developed this encounter data guidance was because this overall process is new for developmental services. And we wanted to add some specific guidance regarding how the DDS providers should be entering this encounter data. But so this guide should be thought of as a supplement to all the standard claims processing information that's available through Medicaid. And if there's ever any conflict between what's in this guidance and what's in the general Medicaid provider billing manuals, the DIVA manuals take precedent there, and we'll make corrections to our guidance if we have something wrong. But they would take precedence. That same thought is also true related to correct coding. So for the submission of claims and using correct codes and the way codes are used, people should be following the AMA current procedural terminology, or CPT, and healthcare procedure coding system HCPCS manuals. And if there's something that's changed in those systems, which they do get updated on, I think on the calendar year, or sometimes possibly in between, but you know, generally providers need to keep up to date with changes in those manuals and how they're coding and reporting and submitting claims. So again, those, if there's a change that in their manuals, those take precedent over what we have in our manual. And we'll try to catch up if we aren't aware, or if we become aware, we'll change our guidance to keep up. But if for some reason you all of a sudden you start getting denials on something that was going through before, it could be because something's changed. And if we're not aware of it and we need to make changes in the MMIS system, you should definitely let us know. Jessica Bernard, her contact information is on page 17, and we can troubleshoot any problems of that nature. So I'm going to pause right there and see if we have any questions.
We have one question coming from Becky in the chat. I'll read it out to the group. Is it possible when you make changes in the guidance in the future to mark them so we can easily tell what the changes are instead of having to read through the entire document each time to try to find them? I have printed all the manuals from the links, but can you tell me? Oh, that's a second. We'll get to that second question after. But Becky, yes, I think that's a very, very good question. You probably don't want to reread a 77-page document every time we make a tweak. Claire, I don't know if you've decided about how we want to roll out changes, if we're going to reference it in a memo or highlight sections in the document.
I think what you just said makes sense. You know, this current update, there was a lot of changes, and so it was a little bit challenging to highlight everything. But going forward, I wouldn't imagine that the volume of changes would be that great. So yeah, I think that we could send out a memo and also highlight where the changes are in the guidance moving forward.
And then the next question in the chat, and I think the final, I've printed all the manuals from the links, but can you tell me where to access the AMA and healthcare procedure coding system manuals?
Erin, do you know the question?
I believe those, well, I know that I have to purchase them. So I believe they need to be purchased to actually get your hands on the books themselves. And off the top of my head, I unfortunately don't know, you know, fortunately for me, someone else in our administrative services unit does the ordering of the books. I'm sure there's some place online where you can find information about how to get your hands on coding books. And I think there's also general resources available online, but probably not as in depth as if you were to actually purchase the coding books themselves.
Okay. Do we have other questions?
That is everything in the chat so far, so I think we can open it up to the floor.
I did scroll through and I don't see any hands raised at the moment. So if folks want to just go off mute and pop in, or raise your hands if you'd like.
Okay, sounds like we can move on. All right.
Yep.
So The encounter claims you have to report all the services that are delivered to a person. And it should, when you report, it should correspond to the time period that your agency is billing for home and community-based services. So in other words, when a monthly paid claim is submitted for a person for their home and community-based services, there should be some corresponding encounter data for that month. If there's, if a person's not receiving any services and you're not billing for that month, then we don't need anything. But the two should line up, and it's you don't have to put them in any particular order. So you can submit your paid claims and then submit your encounter, or you can submit your encounters and then submit your paid claims. It doesn't matter, just as long as by the time period, which is the timely filing rules, which generally is 6 months from the date of service, as long as by the time you hit that timely filing period, both the paid claim and the encounter are in there, that's fine. So the only exception, there's an exception for that, which is right now we have in the home and community-based services on your spreadsheets, there's a column where we're providing some infrastructure grants to providers for employment services. And that was specifically for some people who don't have home and community-based services. But as long as the person has Medicaid, even though they don't have a home and community-based services plan, the funds that are in that column of your spreadsheet are for those people. And so you can report, you should report your encounters for employment for those people. Does anybody have a question about that? Okay. Looks like there's not, so we'll keep going.
Not seeing anything yet.
Okay. So again, on the encounter data claims, the MMIS is going to recognize those as encounters and pay zero, regardless of any charge that's put on the claim form. There's a field in the claim form where people can put in a charge. So because ARIS, the people that are paid, the workers that are paid through ARIS, those employers of record can pay anything they want. Well, not anything, but within a range. They can pay a different hourly rate. And so there's no way to standardize, the rates that are attached to the work that's provided by those workers. And so what's going to happen is that ARIS will include the cost in their claims that they send over to the agency. It's called an 837 claim file. And it's basically all the encounter data that will be sent to the provider to then submit the claim. But they will include the cost of what the employee was paid, plus the employer taxes and the sick leave funds will be included, and along with how many units of service. And when the agencies then submit those encounter claims that come over from ARIS, you'll need to put that dollar amount on the encounter to make sure that transfers from what you get sent from ARIS. So, and then the other thing, this is a change from the last encounter data guidance that we had before, but we actually discovered that The MMIS system requires some charge to be put in that charge field, that there has to be an amount. So for the services that are provided through agencies, you could put a charge amount in there, but you don't have to. But if you're not going to put in an actual charge, what you have to minimally put in a penny. So because the MMIS system requires something. So that's something that's different than what we told you the last time that we discovered. I already mentioned the timely filing. And so also on encounters, there is a thing called place of service. So for every encounter, there's a code that indicates where the service was provided. And these are the ones that we have selected at this point in time for the developmental services place of service code options. So when the claims go in, it has to include one of these. So you select the one that most closely represents where the service was provided. 53 says community mental health center. That also means a developmental disability services office or facility. They're just in national correct coding. There is no, for whatever reason, they don't have that label, and so this is the one that most closely represents the type of work that we do. So it's still labeled as community mental health center, even if you're not one. And then you always have 99 as an other unlisted facility if the others don't match. Okay. So for ARIS, for the workers, they're going to put in, they will include the place of service codes. For workers, will probably mostly they'll be putting in 12 for home and 18 for community, and then they'll use 39 for adult day. And for adult day, that's just for people who are self and family managing. If somebody who's share managing or has agency managed services is attending an adult day, those should go through a subcontract with the provider agency and not be paid through ARIS. And the adult day that would be paid through ARIS is just for self and family management. On some of the I didn't write this in here because this just happened yesterday, but for the non-payroll expense forms that are sent through ARIS for the encounters, I've worked with Jennifer Garabedian to identify the place of service codes that they'll be entering for those types of services, and it'll be one of these 5 codes will be attached. So one of the things that in order to identify which services are running through ARIS, which will be an important thing for us to know in the future when we're doing reconciliation, we needed to have a way of identifying that it was a service that was paid for through ARIS. So on the encounter claims, there's a field for the billing provider, and then there's a field for the rendering provider. So the billing provider is your agency's provider ID that you use to submit the paid claims. So it'll be the same provider ID that your agency has for the paid claims that you'll use in the billing provider ID location on a claim. And then when it's coming through ARIS, under the rendering field, ARIS has a unique provider ID that they'll enter enter into the rendering field. And that's the way the state will know that that was a service that was paid for through ARIS. We added some modifiers. So modifiers are some additional codes that are used with certain service codes to help provide additional information. And we did include a U3 through U5 modifiers, but we're not using them right now. And so you don't need to, you shouldn't use those right now because they're not defined. It's for potentially the future payment model. So, you know, as a general rule, you submit an encounter after the person received the service, and you only report when a person received a service. So there's only a few exceptions to that. So in terms of shared living, we generally think of a person continuing to receive shared living even when they're temporarily not in the house that day. If they, you know, are visiting their family, they're at respite, they're on vacation, they're at camp, you know, or hospitalizations up to 30 days, which are things that are outlined in the system of care plan. We still consider the person to be receiving shared living. So you would enter an encounter data claim for days, even if they aren't in the home under those circumstances. And, you know, again, the reason being that the shared living provider is essentially considered to, they're still offering a home to the person, and they are on call. You know, if something happens, they have to respond. So, and also, of course, the providers have to keep paying for them. So that's why we're allowing the continued reporting for that, even though they may not have been in the home that particular day. And then there's one other exception later that I'll get to, which is around camp, but I'll explain that when we get to it. And then, but you shouldn't be reporting when, essentially, what you shouldn't report shared living when services are suspended according to the system of care plan, which is when someone's in a level 1 psych bed, past the first 30 days of hospitalization, if they're in a nursing home, if they're in jail, or other reasons that services are either suspended or terminated. So I'll stop there. Are there questions?
We have a few questions coming from the chat. First, let me just say thank you to Kim McClellan. She shared a link to the CPT code book through AMA. So thank you, Kim, for doing that so quickly. And then Kathy Monty asked, will we be allowing O2 for telehealth? And Linda added to that by saying, or phone, would we ever use this?
Okay, so we know that we have, we need to do some work around telehealth, and it's kind of complicated in terms of like when you use a telehealth code and when you don't, and what are the temporary allowances that we've set up related to the pandemic. And so Jessica is actually working on that issue right now to figure out when we will allow a telehealth code. And then we need to develop some guidance for you, and then we would also have to set up some additional code in order to allow for that. You know, I think for the most part on the mental health side right now, the code that's being used is the 99 for other unlisted facility for a lot of the temporary telehealth that's happening right now. And some things, again, they, you know, could be not necessarily meet the definition of telehealth, but it could be just the phone only. And so we need to unravel this issue and then get back to you about that. So it's on our radar, but we don't have all the answers yet.
Great. And then Linda also asked, for the ARIS provider, we have to send the claim with that number and not our HCBS one? Question mark.
Okay, so, right. So just to clarify, on every encounter claim, there's a place for the billing provider, and then there's another field for a rendering provider. In a lot of cases, when it's an agency provided service, the billing provider and the rendering provider is the same, except for in circumstances where there's a licensed clinician. It is added in the rendering field when it's a licensed professional, like a psychiatrist or a therapist. But for most of the DS type services like employment and community supports and service coordination, that they don't have unique rendering provider IDs, so that agency would often just put their billing ID in that rendering field. But what we're doing is to help us identify those services that are provided by ARIS, that were provided by workers who were paid through ARIS or were paid for through ARIS, is we're asking the agency would put their provider ID, their billing provider ID in, and then in that field, and then in the rendering field, ARIS will enter a unique provider ID that identifies that this was a service that was paid through ARIS. Am I answering your question?
Okay, hopefully that's a yes. Otherwise, Linda, definitely jump in. The next question in the chat is from Kim McClellan. Kim, I don't know, you might end up wanting to jump in. I think you typed this during the SLP portion of the conversation. You wrote a service and not 6 units to bill for the month.
So I know there's a pending question out there about the 6 units because when we started the new monthly per member per month billing method, we said a provider could bill as long as one service was provided for the month. And then in some updated guidance related to the pandemic, we put in another document that 6 units had to be provided. When we were talking about 6 units in order to bill for the month, what we meant is across all service categories. So any 6 units of service. Jim Huber, Selena, and I are discussing that disparity in the guidance that we provided you, and we haven't gotten to the final answer, but we talked about it this week, but I haven't heard back from them what the final answer is. So we'll get back to you very soon about the final answer on that, about whether you should bill at 1 unit or 6 units during the month. But in terms of encounter data, though, as long as you keep putting in your encounter data based on whatever service you delivered, and so that you know that will be your way of tracking if you got up to 6 units of service or not. Is there a follow-up to that?
Not in the chat. I don't know if Kim, if you need to jump in, please do. Otherwise, we can move on to Brent Huey's next question. I thought I heard you say the adult location was for self and family managed, or did I get that wrong? It's only for agencies to report if using HCBS funds to pay for contracts with an adult day provider, question mark.
Right. So what I'm saying is, if somebody from your agency, so if they attend adult you should have a contract with that adult day. Your provider agency should subcontract with that adult day for that service, and they should send an invoice directly to your agency to pay for it. That's outlined in the requirement to do it that way is outlined in the system of care plan, related to who can be a provider and how subcontracts work. So the use of the 39 for adult day as a place of service code, your agencies would still use the 39 on the encounter to show that. It's just that you wouldn't have that person submit the invoice to pay for adult day through ARIS. It's only allowed that people who are self and family managing can submit their invoices for adult day through ARIS.
Okay, thank you. I think that helped me understand. I was tripped up by the paid by ARIS part. So we're still submitting our claims. We would encounter our claims for those contracts that we have, run them through our EHR and use the location code of 39 to submit that at MMIS. Okay.
Correct.
Thank you.
Yep.
Great. And last question from the chat so far from Mandy Sanders. Why do most activities have all service locations as approved locations?
We did not want to get too prescriptive of that, so we're assuming that you'll use the correct one that fits the service. I mean, one thing you could do with it, like when you set up your system for reporting of these encounters, there may be, you could potentially hard code it so it doesn't have to be selected every time. So for example, all your residential services, if you're putting in a claim for residential service, obviously the place of service is 12 home. So you could set it up that way if you want in your system, but we left it open so that they're allowable, but you select the correct one.
Okay. We have the option to do that in our EHR as well for other services outside of shared living. And I believe that in our process of communicating with each other that there is some confusion as to which would be the best choice for some. I can't give you some specifics, but I can definitely reach out to some of our consortium members. And so maybe a more direct or specific service code would be helpful.
Certainly reach out, and we could answer your question if you're considering something that, I mean, the only thing is that, if there's a possibility that it might be provided in more than one location, you wouldn't want to just select one. But if it's always, if it's totally a logical connection, then that makes sense.
Thank you.
Claire, this is Erin. I just, because you're doing so much, wanted to offer you a time check that we've got about 45 minutes just to kind of help orient you on where we're at in the presentation.
Thank you.
Yeah.
Okay, so get a move on. Okay, so here is a section about the times that are associated with units of service. And you'll note that in Appendix B, for each service code that we have, we included what the unit of service is. So typically there are 15-minute codes, there are 30-minute codes, hour, day, and month are some of the times that are associated with different types of service. And there are different rules regarding the reporting of units and the way that you translate the amount of time that was spent into a unit. So just oversimplifying, two examples are when there's codes that have a unit associated with them that's not in a sequence. And let me just pop to Appendix B. Okay, so here's an example. So psychotherapy, otherwise known as individual therapy, this is a code that's in a sequence. So there's this code, and that code, and they're all individual therapy, but they have a different time unit attached to them. So that's what I'm talking about when I say that it's a service code in a series. And in those cases, you choose the code that's most closely matches the amount of time that was spent. So if you're closer to 30 minutes, you choose 90832. If you're closer to 45 minutes, you choose 90834. So, and those things are subject to change, and so you have to keep up with the coding manuals so that you're keeping up to date with the time that's associated with a unit of service. And then there's another thing called the midpoint rule, and that applies to some of the codes that aren't in those sequential typical times. And for those, here's an example of a 15-minute code, and what the midpoint rule is that the unit is defined as 15 minutes. And it's considered that you've provided 1 unit of service when you've passed the midpoint for the time assigned to that code. So in the case of a 15-minute code, once you hit 8 minutes, you've delivered 1 unit. And if you get up to 23 minutes, you then report 2 units. And if you get up to 38 minutes, it's 3 units, and so on. So once you crested the midpoint, you go up to the next unit. And that's how those are reported. Same thing for 30, 50, and 60-minute units. Do people have questions at this point?
Nothing in the chat.
Okay. So moving on, I just want you to know that for all the services, we have there are modifier codes that indicate the staffing ratio. And again, I can just quickly get to that. So there's a modifier code that regarding staffing. So U1 means 1-to-1, U2 means 2 staff to 1 person. And then you go up here, this means 1 person, 1 staff person with 2 people being served, et cetera, et cetera. And so those staffing ratios are attached to most of the service codes. And just to clarify, when you're submitting a claim for 2-to-1 staffing, your encounter would reflect the amount of time that the person received the service, and with the attached modifier of U2 indicating that it's 2-to-1 staffing. So then, like in the future, when we do reconciliation, like you'll get credit for a higher rate of reimbursement, but the number of hours that the person received would still be reflected. Because if you put in twice the number of units in a day, if you did it incorrectly by doing it individually by staff, you might run over the total number of units that's allowable in a day. So that's why it's important to make sure it's reflective of what the person received. The other thing is to keep in mind that go to attachment D. This is the list of the allowable code modifier combinations. And so this is the procedure code. HW is going to, that means that it's a home and community-based services in DS. And that's going to be on every claim. And then you have your modifiers, which are the identifying the staffing ratio. And then we have 76 and 77 modifiers are allowable. And those reflect being able to submit separate encounters of the same service in the same day, either by the same worker or by a different worker. So 76 is for the same worker and 77 is a different worker. Those codes are being added for March 1st. You can see that some of these things were already set up and some will be by March 1st. So just what I want to point out here is you can only submit claims with a combination that's listed here. So when you're setting up your systems, you just have to make sure that you're, you need to look at this appendix for the allowable procedure code modifier combinations, and only those that are listed here would be accepted by the MMIS system. If you don't, if it's a combination that's not one of these, then you will get a denial. All right, let's see here. One thing about the staffing ratio, like if the staffing ratio changes during an employee's shift, you would put separate encounters in. So if it was say 1-to-1 for 3 hours, that would be one encounter, and then that worker continues their day, but now they're working with 2 people, then additional encounters will be submitted with that separate staffing ratio that reflected how many people they were serving. And then the other thing is that for group homes, for the purpose of simplification, because there's so much variation in like how many people would be actually present on any given day and what your staffing ratio might be on any given day, what we're actually asking for in terms of the use of the staffing ratio modifiers for group living is to just tell us the actual size of that group home. So if it's a 3-bed group home, you're going to use UP. If it's a 6-bed group home, you use US, regardless of vacancies or how many people were there on that day. We'll be able to tell who received a day of service by looking, at the individual encounters that you're submitting by the day for each person who's received group living in any given day. Okay, so are there questions?
Nothing in the chat so far.
Okay.
And I am not seeing any hands raised, but let me scroll through once more. Okay, not seeing any hands.
Okay. Again, the use of 76 and 77 modifiers is allowable. And again, you'll have to look at that Appendix D to see when it is and when it isn't allowed. I mean, there's certain times where we just made a decision to not allow it because it didn't make sense that that service would be repeated in a day. And then in other cases, it's not feasible to repeat in a given day, because like if the unit of service is a day, you can't have 2 days in one day. So we left the 76, 77 modifier off of some of the procedure codes. We're going to send, we've been having lots of discussions with the billing managers on this whole how to use the 76, 77 modifiers. And we're updating what we had shared previously, and we will send that out to give more guidance regarding what we're expecting there for the use of those modifiers. But so stay tuned. Okay. The other thing is that this is new change, and this because in the past paid claims for developmental services were bundled, and they still are bundled. The MMIS system expects to see that Medicare and other private insurance is billed first before Medicaid is billed. But the typical system for that was not, the MMIS system procedures were not picking that up because we weren't putting the individual services claims through the system for things that are like clinical services like psychiatry and therapy and things like that that might be paid for by another insurer. And so now that we're submitting encounters into the MMIS system, this is now going to become visible. And those encounters will be checked to see if Medicare and third-party insurance has been billed. And again, this is just for clinical services, not for other types of service. And there's a bunch of work that we need to do, and I'm going to be talking to the DS directors next week about how we're going to deal with this whole issue of third-party billing. So I think you can just hold your questions related to that, and we are going to be doing some follow-up. But in the meantime, you still will get paid for those services through your monthly bundle payments. So it'll just be a matter of potentially you may be getting some denials on some services that you're submitting for encounters. Oh, and there's my dog helping me with my presentation. Sorry about that. The working at home. Okay. So I'm gonna jump to the to some of the appendices because I just want to quickly go over those and make sure that we have enough time for questions. So okay. I already showed you this. These are the modifier keys. Again, the HW goes on every claim, and then you have your staffing ratios here, the U codes. This U3 through U5 we're not going to use right now, but we may be using those later. And again, the 76, 77 modifiers and what their definition means. And then we have Appendix B. And this is all the information about each procedure code and what's associated with each of the procedure codes. So here you'll see the old MSR code that's associated with the new procedure code that we're going to be using for encounter data. So you can do a crosswalk if that's helpful. And again, the first modifier is HW, and again, that'll be on every claim. The next modifier would be for your staffing ratio, and then the 76, 77 if it's a repeat service in a given day. Then you have your service description. And I just want to point out here, so as an example, it says psychotherapy 30 minutes with the patient. And that's the either CPT or HCPCS service description. And then we have our own Vermont Developmental Disability Services definition. And that is, it's either going to be the name that we have on our service definitions that are in the system of care plan, or if it's a new service, we came up with a new Vermont specific name for it that will be more recognizable to folks. So if it doesn't have something in parentheses for a DDS service description, then it's just whatever the standard definition is in either CPT or HCPCS. This column is the notes column. If there's something special that we wanted you to pay attention to, there's a note in there. You have your minimum and maximum units that you can submit for it's usually per day, although occasionally, like if the unit of service is a month, it means that you can submit, it tells you how many minimally or maximally you can submit for that month. And then you have your units per service. So some of the units they're what we call untimed. So here for psychiatric diagnostic evaluations, the unit of service is just one session. It doesn't reflect a number of minutes. And so it could be any length of time. There's no minimum threshold for that. And then we identified whether the midpoint rule applies or not. And so if it doesn't say anything in there, that means it doesn't. If it does, it says yes. These are the place of service codes that are allowable. This prior authorization, that was more for our Dale's purpose, and you don't have to worry about that, but PA means prior authorization, and that it's no for all DS services. So there's no requirement for prior authorization for these encounters. And then the pricing is also just something internally to Dale that you don't have to worry about. And then this is your provider type and provider specialty. So this goes on the claims too, and this just indicates that it's a home and community-based services and that you're a home and community-based services provider. So there's a couple of things I wanted to point out in this. The codes that I have highlighted are codes that we added for March 1st. And the codes that aren't highlighted, they had been added back in October of 2019 and were part of the encounter data submission guidance that we sent out last January. So those were already available, and these are new ones that will be available starting March 1st. These 4 codes are for psych testing. The other thing I just wanted to point out on these are MedCheck codes, this 99211 through 215. And in January of this year, they updated the number of minutes associated with those codes. So that's something you'll want to check in your system to make sure that you've updated your systems to the new time limits. let's see. Since last time, we added 2 more codes for supported employment. One to reflect employer and job development, and one to reflect employment assessment. And just one thing to note about employment assessment is the unit is 1 day. And up here, the job development unit is 15 minutes. So essentially for supported employment, assessment, if you provide any employment assessment on a day, you would submit a claim for that. And it essentially doesn't matter. The amount of time spent doesn't matter in this particular claim. So we added a code for mileage, and this mileage code is only for those workers who are paid through ARIS. This is not for agency hired staff. It's only that, so there is an option for employers of record to pay some mileage to their workers out of either community supports or employment supports categories. And if they choose to do that, this is the code that they would that would be used to submit for that, and that will be on the encounters. But again, it's not for agency staff. Your transportation costs are incorporated into the services that are being delivered. So we are not asking for reporting on that for agency delivered, just for those who are ARIS paid workers. So this is something new. So this is where there's a new definition for supervised living. So supervised living, starting in March, supervised living, the definition is just for those people who live in their own home or their own apartment. So not for people who are living with their families. So this is a new code that you'll use for people receiving supports in their own apartments mostly. And if some people, own their own home without being supported by their family. Let's see. There's just a slight change for shared living. So the service definitions say not licensed and licensed. But the change though is that it's for you would use S5140 for any adult who's in shared living, and you'd use S5145 for children. And a lot of those are licensed by DCF, but even if they're not licensed and it's a kid under 18, use this code, this S5145. So this is a new code that we've added for remote supports. And again, this is a service that's not provided by every agency. It's only used by some agencies. Some folks may have heard of it. It's called Safety Connections. That's at the Howard Center. So there's 2 codes for that. One is for the monthly fee to have remote supports, and then a code for when the system gets set up in somebody's house. There's a few other agencies besides Howard Center that are starting to use this option, but not everybody does. So if you don't have to worry about these particular codes. We did add a code for home modifications. And basically that you're going to put, you can submit your encounters for any home modifications. If you're going to submit them on one day and there's more than one expense, you just add up the total cost and put that under one encounter. Or you could put, like if there's more than one home modification done, you can put those on different days. T2012 is a code that we've been able to identify for the post-secondary education programs and technical training support. The post-secondary programs are like Think College and College Steps, and the technical training support is for a few people who receive Project Search and are adults that use their home and community-based services to pay for it. And again, this, you only report this for when home and community-based services are being utilized to pay for post-secondary or Project Search. If it's grant funded, you don't put in encounters for that. And then this T2017, this, we changed the definition. This used to be the code for supervised living, but now we're calling it in-home family support. It's a new category of service. And the definition is that it's intermittent supports to somebody that lives with their unpaid family caregivers. And then, but we're also using that same code for shared living hourly supports. So that's when a shared living provider has additional hourly supports coming into the home. So again, that if the person lives in their own home or their own apartment, you're going to use that other category of supervised living. And if they live in their in-home with their family, you'll use this. For community supports, I'll jump down to that when we get to the reportable section, but there's three different types of community supports. We have individual support, which is either 1-to-1 or 2-to-1, group, and then group facility-based. And when I say group facility-based, what I mean is it's in the person's receiving some type of day service in a facility that's operated by an agency. And then we have camp. So this is the one exception where we're going to allow, so people can use their respite dollars to attend camp. And so we identified some codes for that. One is if it's an overnight camp, and one is if it's like a day camp. And when you put in the encounters for that, it's one full session of a like overnight camp. So for example, if it's a 2-week session, the encounter would, the unit would be 1, and then it's for that 2-week full session. And then there's a cost associated with that that's entered on the encounter. And same with the day camp, you add, it would be for the full, like if they go for a full week. And so the problem with the camps is that people typically pay for their attendance at a camp out of one fiscal year, and then they attend in another. And the only way to reserve their spot is to pay for it. So this is the one circumstance where we're going to actually allow the encounter to be put in before the person actually attends and receives the service. And then we'll follow up with some more instructions, but if for some reason an encounter was put in related to that, to paying for a camp, and then the person doesn't end up attending, we'll have a procedure for how you return the funds and reconcile the fact that the person did not attend after all. But that'll be coming later. We haven't written it up yet. Okay. All right, I'm gonna stop there. are there questions about that? I know I kind of went over that pretty quickly.
We do have some questions in the chat, so we'll start with Melissa Hunter's question. Claire, is this guidance saying we are only allowed to have one individual therapy service per month?
No, one individual therapy service per day.
Great. And Kara has the next question. Could you please clarify, did you mention that there were Vermont definitions for service codes?
I'm sorry, can you say that one again?
Sure. Could you please clarify, did you mention that there were Vermont definitions for service codes? So in parentheses.
Okay, yeah. So yeah, let me just show you. So the service definitions will be right here in this Appendix C under the reportable services. So in each section under that reportable action, there's a service definition.
I think, and Kara, please correct me if I'm wrong, I think you may have been referencing where we have to use the code that is set forth in the manual, but like in parentheses, we have things that say DDS service description, like there's a Vermont quote unquote definition. So
Yes.
I think just clarifying that.
Yes, that's what I was asking.
Yeah, okay. So one thing I'm gonna do, which I haven't completed yet, is I'm gonna come up with a document that has for each code what the service definition is, the associated code, the old MSR code, and like it'll say what the HCPCS or CPT code is, but then also the descriptor and then the definition. And then I'll create a quick reference for that because I'm sure that will come in handy eventually.
So I think it's safe to say that right now, if you see in the service description box, something in parentheses that says DDS service description, that's our language, not, we have found moments where we don't necessarily agree with the coding language, but we are required to use it.
Right.
And next question from Brent. Section AA for 76 and 77 modifiers says, quote, may use the 76 or 77 modifiers to report separate repeat encounters on the same day for the same service. Does may use indicate not required? We are facing an issue where we don't believe our EHR can do this in a manner that would be feasible or produce clean claims from the end users. Is this required, or can we roll up each of these services into one claim per day, even if it was performed by different staff people, thus completely ignoring the 77 modifier and not using either 76 or 77 modifiers, just rolling up the claim?
Yes, absolutely. Yes, you can roll up the minutes provided by either one staff person or multiple staff people in a day. I mean, the only complication with that is if a service is provided by a licensed clinician and you're including the licensed clinician's unique provider ID on the claim, so for like therapy or psychiatry, then that could, you'll want to apply the 76, 77 modifiers to those as appropriate. But for other services that are not the clinical services, what you're suggesting is fine and actually is recommended.
Okay.
Yeah, Claire, this is Erin. I just add, I think it's more of a systems issue that you're describing. Like if the system sees that there are different, multiple services submitted in the same day with different provider IDs that didn't have that modifier attached, you might, have a duplicate. It might view that as a duplicate service. But it sounds like what the person who asked the question was describing wouldn't do that because you're just rolling it up and submitting it all under a single claim. So that helps.
Great. And we
Did
have,
get, yeah, did that answer your question, Brent?
Thank you. Yes, it did.
Okay.
and Vicky from NCSS is wondering, when we have a client with Medicare and bill that first for therapy or psych services, Medicare does the crossover to fee-for-service Medicaid. We receive an actual payment. Should that be recouped and then the agency would bill waiver?
So again, we need to work through some of the procedural pieces with this Medicare, Medicaid crossover claims, but yes, what you're saying is correct. So the amount that would get charged to the waiver, the home community-based services, would be the residual amount after private insurance or Medicare paid. And Jim Huber has sent some guidance about that when we switched over to the per member per month billing mechanism. And so like if you had gotten paid like the full amount and then you received reimbursement from Medicare or a third party, you would just with the per member per month methodology that we're using right now, you would reflect that on the information that you send back to the department as some revenue received, so that he would then deduct that from your overall agency allocation. And that's how that's being addressed right now. And again, we may be coming up with something else for the future, but that's how it's going to work right now.
So in a nutshell, we should not be receiving any Medicaid money from any other, we should not be receiving any other Medicaid money other than the PMPM.
Correct.
Okay, thank you.
Is that what's happening though? Is Medicaid paying it?
Yes.
Yeah, Claire, sorry, this is Erin. My call dropped right as you started answering the last question. I believe that in the case of what's known as crossover claims, where a provider first submits the service to Medicare for billing and then it electronically interacts in some way that I don't have visibility into with Medicaid's billing system, the only option for that claim would be to pay, you know, the remaining balance that's indicated on that claim. It can't zero pay as our other
okay.
other encounters would. Yeah.
So this is part of what we have to work through.
This is Rita at Washington County right now. Medicaid does not pay those because there's an edit in place. Because of the waivers all inclusive, it does not pay it.
For the DS program?
Correct.
Well, I mean, historically, the only thing that would have been available for MMIS billing was what used to be the daily bundle rate and what now is the monthly. So I'm not sure, you know, how that applies now that we're integrating all of these new procedure codes for zero pay and counterclaims.
Oh, hopefully it can stay in place.
This is Bill Claessens. I have a question. What if the individual therapy, in this case, that is carved out of the waiver, it's not included in the base amount? How does that
Right.
back?
So if it's not in the home and community-based services, then you wouldn't be submitting encounter claims for that.
Thank you.
Okay, so if we get back to the questions in the chat, we have Brent Huey looking for clarification for camp codes. So to clarify, a 2-week session of camp is 14 units, or i.e. 14 days.
No, it's the unit would be just one.
Okay, thank you.
Great, we have plenty more questions. This is a popular stopping point. So from Bill, for camp codes, Bill Clayson's, for camp codes and home expenses, we are to put the actual amount paid with the encounter, or can we put it in a set amount? I'm trying to determine how an EHR can have a variable change for service types like these, as there will be variable amounts.
Yes, you can include the paid amount there in the charge field.
That's gonna, I would think for most EHRs, that's gonna be difficult. We'd have to have a separate service type for each type dollar amount. Either that or we'd have to, anyway, it would become difficult to change the charge each time we have a service. So that will be interesting to figure out. Thank you.
Right. I mean, what we're trying to do is allow for the flexibility that some of the charges are not going to be there won't be a standard amount.
Okay, and so I think this is our last question in the chat from Emily. You stated with camp services, we will be able to enter these services T2036 and T2037 in advance. So Medicaid will not deny these services due to service dates in the future?
Correct.
I think this is Erin. I think you're going to have to put a date of service that's not really the date the camp began. You're going to have to put a date of service that's in the now, not the future, or else the claim would deny.
So maybe the invoice date or payment date?
Yeah.
Yeah. And so the service is, I mean, like conceptually, it's the service we're paying for is holding their reservation.
Okay, that's everything in the chat. We have about 3 minutes left of our scheduled time together.
Okay, so I'm guessing that there'll probably be a lot of questions related to this, but just so only have time to describe what's in this. And then I would ask that if people need clarification regarding what's reportable and what's not reportable, that you email me your questions and I'll send out the answers as part of that frequently asked questions document. So what's in this appendix is the service description. Then there's a service definition and what actions by the service provider are reportable. And then in these two columns, you have what's not reportable. And this column is for the agency staffed or agency contracted services that are paid for through the agency. And then this is for, the final column is those services that are paid for through ARIS and what's allowable and what's not as a reportable service. And so in this column, in some cases, there's something that applies specifically just to people who are self and family managing, and that's identified. And sometimes it applies to all the services paid through ARIS. So just so you know how we came up with this framework, there was as part of the payment reform process project, there was a rate study conducted by a consultant where we collected lots and lots of information from the providers regarding their costs associated with providing a service. And so some services are considered basically what's in the reportable section are direct services to a person or on behalf of a person. And then there are what's in the non-reportable sections are things that are considered associated actions by a provider that are infrastructure that supports their ability to provide a service directly to somebody. And so it's not that agencies are not going to get credit for these activities or that they won't get paid. They are incorporated into the rates that will eventually be associated with each encounter. In some cases, for those ARIS paid workers, they actually don't get paid for some of these things because there's no mechanism for doing that for people that are using those independent workers. So again, it will be important as you set up your systems to be able to report, to make sure that you're reviewing this appendix to see what's allowable and what's not allowable in your reporting of service. And so it's kind of long. It's quite a number of pages. So you should go ahead and take a look at that. We're running out of time. I was afraid that we might not get to everything. But you know, as you review this, please do send me any of your follow-up questions. I know that this section can sometimes be confusing about how it's supposed to work and when you're supposed to report what. So, and then we already looked at this Appendix D, and this is your inclusive list of codes and modifier combinations. And then there's two more appendices at the end. This is your, oops, they're not DXC anymore. I didn't make that update. They're Gainwell now. And if you click here, that this will tell you who your provider rep is that can provide assistance with claims. And then this is your appendix of some helpful guides in DIVA. And we are actually over time now. So I would say, please, to everybody, if you had remaining questions, if there are things that I didn't get to on this 2-hour webinar, you can email me. And let me see here. I will stop sharing that one and go back to, whoops. Oops, there you go. If you have any questions or if you need technical assistance, do email me. There's my email address, and we will follow up with everything. And I just want to thank everybody for attending today. And just to reiterate that this is, you know, this is we're entering the implementation phase. We do expect that there could be lots and lots of questions. We may run into glitches that as we set up our system that we didn't anticipate, and we stand at the ready to try to troubleshoot any problems that folks are running into. So do reach out, and we will try to provide assistance. So I think we are done for the day.
Thank you, Claire.
Thanks so much, everybody.
Thank you.
Thank you.
Thanks.
Thank you.